So let's move on to the next presentation. I think Roopesh has joined now.
Yeah,
Roopesh
yes, sir.
is the next.
Yes, sir. I'll start scale.
Yeah,
Thank
please.
you, sir, for the opportunity. So this is a non-coronary case, and it's something which is uh, pretty interesting. Uh, so the title is Slicing the Way Through, and okay. So my patient, he is a 45-year-old male. There are no significant comorbidities, otherwise healthy. He developed exertional dyspnea of class 3 PND and occasional palpitations of almost 3 to 4 months of duration. There is no significant family history. ECG had a lot of LVH with strain pattern. On echo, there was HCM with LV outflow tract obstruction, and on angio, there were normal coronaries. We were thinking of alcohol septal ablation, but there were no suitable perforators. So this is his echo apical fourth chamber view, significant amount of hypertrophy. In fact, there is even the lower part of the septum is involved, but as we can see in the plaques view, there is some amount of asymmetrical septal hypertrophy, and we can see the SAM in this. This is short axis just to demonstrate the level of hypertrophy. So I was measuring the septal thickness. The maximum septal thickness was around 32 millimeters, and to demonstrate the sigmoid hypertrophy, uh, the uh, uh, the basal septum is almost 32, and towards the other side it goes down to 26 and 19 millimeters. So this was the patient, and we then counseled him for septal myotomy. Uh, for There was some sort of religious kind of, he was absolutely against surgery. Uh, so despite, we kept him on like a high dose of beta blockers and calcium channel blockers for a few months, but then he did have some level of dyspnea. So we sort of were thinking what to do with him. The maximum gradient, this is the resting gradient. In fact, it was around 150 millimeters of mercury. So we got a cardiac CT done. We were thinking just to demonstrate. So this is a volume rendering image that I did via Radiant, and this is really not very difficult to do. Just the volume rendering, and I have gradually subtracted and the other part. So here we can clearly see the LA, and we can see just one second. I'll have the, so this is the LA. This is the LVOT. This is the sigmoid shape of the septum. So this is the LV cavity. We can see, if you can imagine, this must be the anterior mitral leaflet, and we can see how the LVOT is getting constricted. So I also analyzed this cardiac CT on the TAVI module that we had. I don't have the mitral access to the mitral module, but based on the aortic module, this is the volume rendering image from 3-man shoe, and we can here clearly see this is the anterior mitral leaflet, this is the sigmoid septum, and we can clearly see the funneling which is occurring in the alveoli. So we took him up for septal myotomy, transcatheter septal myotomy, which was, we planned it under general anesthesia. This is the TE on the day of procedure. This is under general anesthesia. We can see certain moderate mitral regurgitation and turbulent jet getting into the LVOT. These are the cath. This was done in the LO cranial view. The angles I derived, so a lot of planning went into it because I was doing this for the first time. I was looking at this CT for almost a week before I actually entered the procedure. The angles, the cath angles were all derived from the CT. This is an LO cranial view just to see the entire outline of the ventricular septum. This is the RAO caudal view, which was again derived from the septum. This was my working view. Here you can clearly see the anterior leaflet here. We can see the sigmoid shape of the septum. And we can, if you look carefully, certain amount of milking sort of effect is also visible in the LVOT. So we are planning transcatheter septal myotomy, which is known as Sesame, invented by Jafar Khan and the other electrosurgical guys. This was the gradients. This is the just to demonstrate the broken bone marrow phenomenon. This is the resting gradient. Again, here the peak-to-peak gradient is around 60, but this patient is at this point under general anesthesia, so maybe slightly lower gradients. So this was our septet. From one femoral limb, from the right femoral, we had the 8.5 French Agilis sheath, AL 0.75 guiding. Other femoral axis we use for the pigtail. TPI through the venous axis because we can at times damage the bundle very easily.
Rupesh,
Yes, sir.
I am seeing your slides, but Siddharth has pointed on the chat that your slides are not visible. Siddharth, can you unmute and let us know? Are you not able to see?
No, sir, I am not able to see his slides.
But it is here.
Maybe I mean, is
Yes,
it for
now it's visible.
okay? So
Okay.
so the setup is an Agilis sheath through right femoral axis, 8.5 French sheath. It's a steerable sheath from St. Jude. We have a 6 French AL 0.75 guiding, through which I have a microcatheter Corsair, through which I have a esteto wire. From the other femoral axis, I have the pigtail catheter, and from the venous axis, we have the TPI. So again, the trajectory of the wire has to be planned based on the CT, and it is a two-operator job. I requested a dear friend, my residency colleague, to join me because it's a heavily eco-guided procedure. So everything you need perhaps a more competent person than yourself on echo because it's so heavily guided. So here we can see through based my Agilis sheath, the guiding. I have just abutted the guiding against the just below the membranous part of the septum. So if you can see, this is the membranous part of septum, and my guiding is abutting the septal hypertrophy just below the membranous septum. This is the anterior mitral leaflet. So we wanted to, based on the depth of the septum and the review of literature, we found that 60, 40 or 50, 50 depth. So we wanted to go around at least 6 or 7 millimeters deep inside the septum to do that myotomy. And the initial entry, we were trying to do it via electrosurgery. So this is me trying to enter the septum. Contrary to what we may believe, the rhythm remains remarkably stable. There are runs of PPC which are usually seen only during initial entering. Once you're inside the septum, the rhythm remains remarkably stable. So this is me. It was despite the electrocautery, I was not able to enter. The guide was slipping. I changed my sheath, torqued my Agilis sheath, rechanged my guarding position. It is important that we enter the exact location. So around after certain amount of try, I was able to enter inside the interventricular septum. This is me trying to navigate the I have then passed my Corsair into the septum, and I'm trying to navigate the stato in the septum in the marked locations. But based on the echo, so we were trying to visualize the wire on the echo, and we realize if you see the wire is going here, it is too superficial. So this probably would not help much. And the beauty of this procedure is you can rewire your septum as number of times as you require till you do the final ablation. So we sort of removed the wire back. We realized that we need to go more deeper. So in an RAO caudal view, going deeper would be going laterally. So this is me trying to enter the septum at a different position. And this time again, we check the guide position if it is abutting the septum at the right place. What we need to do is whatever entering we are doing at between the right and the left commissures. We have to stay away from the non because as we know, all the conduction system is below the non. So we entered and we were able to track deeper initially. So this again, this is an LO view where we realize that, okay, we are going more laterally, and then we need to take the wire back down into this vertical sort of fashion so that we can enter back the cavity. So again, back to the RO view. A good marker in this case would be the TPI. So TPI shape is, in fact, if my wire was able to mimic the TPI trajectory, I would get a good sort of septal curve. So again, we were able to wire, we were checking between echo, RO and LO. And thanks to my initial training in the EP unit, that when we were doing a lot of this ablations for arrhythmia, we had a method of doing RA and LO while keeping the table locked. So you don't really lose your position and you can come back to exactly same position. So we use that. Once we aligned the table, we locked the table, and we had strictly instructed the technician not to move it even a centimeter. Only the C-arm moves. The depth parameters, we were able to come back to the exactly same fluoroscopic views. Ideally, outside, like this has been done usually with a biplane lab, but again, that's a luxury that most of us don't have. So this is us trying to re-enter the cavity. This is again the LO view. We have trajected the septum and we are trying to direct our wire back towards the interventricular cavity. So here we can see that we have a substantial depth and of myocardium which is covered, and the wire has is just entering the interventricular the cavity. So next, it was snaring. I used a 30 millimeter snare. I should have taken up the snare with the 3 loops, but I mean that was, so I had to sort of work a little bit here, but then I was able to catch it without a lot of difficulty. Track the microcatheter down, made a V outside, a flying V, as we usually make in lampoons, sort of ablated the surface. So the setup is, this is another guide, 6 French guide wire that we introduced integrately. The pig Corsair is down and we were flushing the guide, but Corsair was preventing any loss of current. So we are just pulling. This is initial ablation. We stopped at one point. We changed over to LAO because we did not want to damage the aortic valve. And this is the final pull. So we ablated the longitudinal cut on the interventricular septum. And then we checked again, because for any VSDs or any myocardial or free wall damage that we have done, but it was not there. So the sigmoid hypertrophy, it is there. We are just making a longitudinal cut and it will splay. So the gradient goes away. You're not removing anything. You're just making a cut on the ventricular septum. And this is the TE. After the cut, you can see the MR has also regressed. The LVOT turbulence has gone down. And this is the gradient from between the LV and the aorta. We did induce a left bundle. Anyways, I was planning this space. I was going, because it is 32 millimeters of IVS, we are going to put in an ICD. We did try to get away from the septum, but before the procedure, it was a narrow QRS, and after the procedure, there was certain amount of bundle damage that was there, but there was no heart block, and this is acceptable. We are planning, the patient is going to be planned for an AICD probably a month down. So no gradients, and in all honesty, this was the, I mean, we were lucky in a way, because probably there was no damage. But to summarize, I mean, it involved a lot of planning. Before this patient was admitted for almost a week before I did the procedure. I was looking at the CT scans daily, on 3-man shows, on radiants. On the day of procedure, I knew my angles, I knew my depth, I knew my direction. I knew how the wire would look in different views. But again, as in all, collaboration with our colleagues is very important. Such procedures need help. We cannot do them alone. Pipeline makes our life easier with this, but that's a luxury we don't have. Echo again is very, very, very important. So like many mitral procedures, it is heavily guided by echo. To best of my knowledge, this is a second sesame case in India. I think one has been attempted in Chennai. I don't know what the results were like before this, but we were lucky to get good results. Again, probably beginner's luck or well planned. I don't know, but it is something that we look into. Based on the review of literature, what I have learned is the conduction disturbance, if done properly, are lesser in sesame as compared to the alpal septal ablation. It is again not dependent on a septal perforator. So even in patients who do not have a good septal perforator, we can do this, and the procedure, once you have an opportunity to correct yourself a number of times. So we can wire again. So once you are satisfied with the final position, only then you ablate. So it is in that ways, the steps in between the procedures are forgiving, and you can do it once if you plan it well. That's all from my side. I wanted to present this in a national conference, but because Acardmy has been so close to my heart, I said I'll do it first here, then only I will present it in probably Vals or something down the line. Thank you, sir.
Thank you, Roopesh. I think this is totally mesmerizing and highly incredible. I think this procedure which you have done, it requires guts, it requires audacity, and to execute it really well. I think this is something very, very scintillating. So all points to you, and thanks for considering to present here, because this is one of the case. I haven't done it. Only few, as you mentioned, one or two procedures are done in India. This is very, very tricky. You require to have a very detailed planning for 5-6 days. CT, which you mentioned, I think you opened our eyes. So that is the idea. That is the idea of young minds coming together. So, this gives you impetus, this gives you a drive, and obviously that drive should be calculated. We cannot really
No, we
create.
had the surgeons, we had counseled him. There is a risk of we can probably damage the free wall. But then, as I was reviewing this literature again, it was contrary to our belief. It is not, if you orientate your catheter away from the non, and in 32 millimeters of septum, it is forgiving at times. So our mistakes, unless you do, it's just that you need a good person at the imaging.
So I think, yes. So few points, I like to ask, because I haven't done it personally. I only read it and saw a few cases. So now one thing, two, three things are coming to my mind after seeing your exceptional case. One, should we really attempt a septal ablation first and then think of that if that is ineffective? That is first thing. Second, did you do it in a hybrid OT and kept everything ready
Yes,
for a
yes.
cardiopulmonary bypass and surgeons ready if
We
anything?
had the surgeon sitting outside. We did not let him go. He said, "You be here." We had everything. It's like if required, the patient could have, we could have gone with the sternotomy immediately. Everything was ready.
So two things are, because this is an initial experience.
Yes,
So
sir.
I think having a cardiopulmonary bypass or a ECMO alongside the patient, that if things do not go as per plan, we should be ready to save a life, because this is very good that things really went as per your plan, and you could actually execute a very good result. So tremendous. I think this is a huge
So,
achievement, and that is
sir,
why.
I have a question, sir.
Yeah, Ajay.
So my question is that we have spliced, we have cut the part of the septum, or we have just ablated a part of septum? No,
It is just
I'm
like
saying
electrosurgery. It's like in lampon.
electrosurgery.
You
Okay.
don't actually cut and bring anything out.
Okay.
We
Okay.
are just
Okay.
using current to create a vertical incision.
Incision.
Probably an incision would be a better word. We are just doing an incision.
Yeah.
Okay.
So
So
it,
how is sir, how it is going to help out in decreasing the gradient if we are just creating incision? It is just like it, that the incise part which
So
eventually
it's like
it
based on the
will
anatomy. If you look at the
necrosis.
anatomy, like the myocardium fibers and three ways. Initial,
Yeah.
if you do the strain echoes, the radial strain, that is the innermost part of the endocardium. So I'm just cutting those radial kind of fibers. So the contractile squeezing force goes away.
Okay. So
No,
did the patient experience any kind of pain or ECG changes like ST
I
elevation?
did it in general anesthesia. I was
Okay.
like,
So
because
post-op,
it is, we are learning. I mean, I was not going to risk that. It was under general anesthesia.
okay,
But
okay.
post procedure, the patient did not feel anything.
You don't have any
There was
check.
a residual left bundle that is
Okay,
there,
okay.
and I did put
Okay.
him on anticoagulation because I was not sure if this cut can produce any thrombus or not.
yeah.
Exceptional,
So,
exceptional.
so
Wonderful,
I
sir.
think, you know what Rupesh is, showcasing here. It's
Yeah.
not going to be easy because then you have to protect the aortic valve while you're
Hmm.
doing electrosurgery. You know, while you're giving electrical impulse on that, everything else should be protected, and especially once you take it back, the significant with a significant pull. Again, you have to see that your electrical
So that is
energy
why
is
we
not
stopped
visible.
during the initial part of the septum. We were in the other view, and when we were coming up, when we thought we are going to reach near the aortic valve, we switched over to the LO view where we can probably better visualize. So during you need to not, as sir mentioned, we can, if the current is still on, you can damage aorta, aortic wall, and a lot of things can go wrong.
No, I have done lampoon. Lampoon is also almost the same, but then again, the protection has to be there, and you have to be very, very careful that you are not damaging the aorta while giving while electrifying the whole stato wire. So I think this is going to be in memory for long, Rupesh. All
So,
Yes,
marks.
sir.
one last question, sir.
Yeah, go ahead,
Did
Ajay.
the gradients came down immediately on table, or it
Yeah,
took some time?
no, this was the, I mean, that result. I mean,
That,
I think it is God's blessing. I did not expect it to come down so much, but
yeah.
it was there on table. The results, the image that I showed was from the same procedure.
No, I think
Okay.
this is great, and I tell you, Ajay, one more thing. So
Yes, sir.
anatomy again has to be very good. So more the sigmoid septal hypertrophy, it makes the easier way of that wire into the septum, you know. So if it is a good, real good hypertrophy, in this case, I think is 36 or something, as
30, yes, sir, almost more than 30 millimeters.
more than 30.
30.
So yes, more the hypertrophy, more the chances of your implantar guide abutting that septum, and then more the chances that you enter with a wire inside, then a corsair. There has to be a good anatomy. So I think this is a huge case, and that almost makes Rupesh as a brand ambassador for Sesame. If anybody wants to plan, let's keep discussing. I think this is no. I'm serious. I'm serious because I think this is the strength of being together. If at all we need planning, I may be good at few things. Rupesh is good at, and since he has done. So I think this opens up the doors that we can consider and discuss and think of doing these exceptional procedures. And now, obviously, the experience counts. We can always discuss and call Rupesh that this is the case, a CT, and send the CT images. So this is how we grow together. Thank you, Rupesh.
Thanks.
Thank you.
Thank you so much, sir.
For the sake, be here up till the end. So
Uh,
for the sake of time, let's move to the next presentation.
Thank you, sir.
Karthik, sorry, next presentation, you take all the.
No, sir. I'm
volume.
really sir. Thank you for presenting, sir.
This is
This case
actually we are spellbound.
Yes.
We don't have words. We are not finding enough for the discussion. And if we keep discussing, I think the whole Academy session today will be discussing this. So we keep on discussing on the net. So anybody
Yes, sir.
on our group, please give all the inputs regarding this case, all your thoughts, inputs, and discussions. Let's keep it for our group, right?
Yes, sir. Right,
Yeah.
sir. Thank you, sir.